transfusion. So you can see the blood being injected through the umbilical vein there. The patient then followed up for an office visit at 31 weeks and 6 days. The baby had the moderate to severe anemia, so it was recommended to have PUBs again in 2 days. And the patient was recommended to go to labor and delivery for a betamethasone course. She presented for her first dose of beta. She had reactive NST. She got her second dose of beta at HemMed at her office clinic. Then she had a second PUBs at 32 weeks and 1 day. This time she was counseled that there's up to a 5% risk of complications from the procedure that may lead to delivery and possibility of fetal demise. The procedure was the same as last time. The opening hematocrit was 28.7. This time the fetus was transfused with 75 milliliters of PRBCs that had a hematocrit of 81. The post-transfusion hematocrit was 51. Afterwards, the fetus had no anemia and a reactive NST. She then had 4 consecutive ultrasounds that showed either no anemia or mild anemia. She was then delivered at 37 weeks and 1 day, vaginal delivery, uncomplicated. It was an induction of labor. The fetus went to the NICU. Her postpartum course was uncomplicated, and she was discharged home on postpartum day 2. The fetus had Apgars of 9 and 9. On day of life 1, the fetus was Coombs positive, had hyperbilirubinemia, and was started on phototherapy. The baby was continued on phototherapy until day of life 5. Then on day of life 6, the baby required a blood transfusion. Then another blood transfusion on day of life 10, and also on day of life 9, the baby was started on CPAP for tachypnea. And on day of life 10, the baby was diagnosed with mild congestive heart failure due to a large left to right shunt across a large muscular ventricular septal defect and mitral regurg. And the baby is still in the NICU here and just increasing PO feeds, but is on room air and no further blood transfusions so far. This was my teaching slide. Should we skip that? Okay, do we have any questions about this case? Sorry, it's fast.
Why was the risk from the first PUBs 1 to 2%, but the risk from the second PUBs is 5%?
I think the counseling was just different. The first one said it was a risk of fetal demise of 1 to 2%, and then just overall risk of complications from the procedure was a 5%.
Gary, that was probably the same person, just giving different numbers. The risks of complications for the first and the second are the same.
No other questions? One thing that I think is interesting is I still don't know when she was sensitized during her pregnancies, because we can't see records all the way back from her 2012 pregnancy. So it could have either been that, or it could have been during her DNC for the missed AB at 10 weeks. This is her OB history. So I'm still curious when it happened.
And maybe the most interesting thing, Morgan, since you have 1 minute, can you show your teaching slide? Did you talk about the trial that's ongoing?
Yes. So first I just talked about what RH sensitization is, but then there's a study that's ongoing right now. It's to evaluate the safety, efficacy, and pharmacokinetics and pharmacodynamics of M281, which is a medication that's supposed to prevent the antibodies from crossing the placenta to prevent RH sensitization. It's administered to pregnant women at high risk for early onset severe hemolytic disease of the fetus and the newborn. And they just are trying to see if this would work. But one of the considerations is that it could prevent all antibodies or many antibodies from crossing the placenta. So it could affect the fetus's immune system.
Thank you, Dr. Dunn, for presenting these cases. We're now going to transition into grand rounds. Just a friendly reminder to please display your name clearly for attendance purposes, and the CME code will be sent via the email system. With that said, Dr. Bachman, are you ready to introduce our speaker?
Oh, absolutely, and I'm thrilled to have this honor. And usually I do not read the entire bio sketch because obviously with Dr. Apuzzio, I've known him for many, many years, but I was so impressed with his bio sketch that I'm going to review it with everyone. And we are truly honored to have him as a speaker today. Dr. Apuzzio is professor and vice chair and the director, Division of Maternal Fetal Medicine at New Jersey Medical School's Department of OBGYN. And he's professor of radiology too, which I didn't know. He graduated Phi Beta Kappa from Rutgers and received his MD from New Jersey Medical School AOA. His residency was in OBGYN at Martland Hospital in Newark, and his maternal fetal medicine fellowship was there as well. He's a faculty member at New Jersey Medical School and serves on numerous medical school and hospital committees. He's also the past chair of ACOG District 3, which encompasses Delaware, New Jersey, Pennsylvania, and the Dominican Republic, and serves on the executive board of ACOG. He's a member of the state of New Jersey's multidisciplinary maternal mortality review team. I told you there was a lot with Dr. Apuzzio, and I was really impressed. I'm almost done. Dr. Apuzzio's clinical and research interests are in high-risk pregnancy, infectious diseases, and OBGYN. And as I said, he's double boarded with certification and recertification in both OBGYN and maternal fetal medicine, has over 125 articles published with over 100 abstracts, and he published a book in 2022, A Hero Walked Here, which is the story of a Rutgers University student who gave his life while trying to rescue a woman from her burning home. I was very impressed with that. I didn't realize he was an author. He was named the 2023 Castle Connolly Guide as Best Doctor in New Jersey and has been listed so for the past 15 years, and also the 2023 Inside Jersey Magazine Best Doc. So again, I am just thrilled to have Dr. Apuzzio speaking with us today. Dr. Apuzzio, the stage is yours.
Great, thank you so much. Can you all see my slides?
Yes.
Oh, good, okay. Gloria, thank you so much. And, you know, as soon as I see you, first thing that pops into my mind is 1, 2, 3 for moms. You know, Maternal Health Awareness Day, January 23rd is coming up. And I want to thank you for allowing me to give this talk today. So I have no disclosures, as you can see. I'm kind of biased on some things as far as trying to follow protocols and so forth. I think they're always very helpful. And you also have some of the objectives. I'm going to talk about cesarean section rates, particularly about NTSV. But before I get to that, I really have to say this lecture and other lectures that are available to all District 3 hospitals that have delivery services is because of our ACOG District 3 program, which started a number of years ago, that supports these type of lectures. And I don't know if Fran Sinofsky's on board, but Fran is our immediate past chair of District 3, and she really did a fantastic job the past several years. These are the newly elected New Jersey ACOG officers. Dr. Gittens Williams is at New Jersey Medical School here with me. Also, Dr. Campbell is the treasurer. Dr. Bruck is at Jersey City Medical Center. And the immediate past chair is Dr. Sabera at Hackensack Medical Center. So I'm going to show this slide to you again later, but we do want feedback of what you all want as far as lectures. You can actually suggest new lectures. There's a whole menu of lectures you can pick from the District 3 website. And this is a QR code. You can copy it now. I'm going to show it a little bit later at the end of the talk. So what is NTSV? Well, it's nulliparous term, which is 37 or more weeks, a singleton pregnancy and vertex presentation. That is the NTSV. The NTSV rate was 23.9, now it's 23.6 or lower. So you want to see where RWJ is. All of the next 4, 5, 6 slides are actually on the Department of Health and Human Services of the state of New Jersey. So your regional perinatal center. That's the highest level of obstetrical hospitals. There are a number of RPCs. For example, here in Newark, we're RPC as well. And you had 2,405 deliveries in year 202. See if I can go to the next one, which I'm seeing. Okay, so where are you as far as your rates? And there's other hospitals there, and I'm not trying to compare because this is the only way I can get this slide from the state. So if you look at the top, it says Robert Wood Johnson University Hospital. And in year 2016, the NTSV rate was 31.4, which obviously is above that metric that I just mentioned. And it actually did pretty good because 2018, it went down to 29.8. Some of you may look at this, say, oh, 31, 29, not a lot. I'm going to show you later. It is a lot. It's a lot less sections, and I'll show you that a little bit later. And 2019, it was 24.2, which is pretty good. But in 2020, it's 26.7. And I'll show you, I think, the next slide. Well, we'll get to that, I guess, but it looks like it's actually gone up a little bit more. So again, here's the report card for RWJ. And NTSV rate here is 28.5. This is for 2020. You'll find some discrepancies in the percentage. Not exactly sure why, but again, this is all DOH information that they put out there. They actually have other things, episiotomies at 2.8% and so forth. And then they also mentioned about VBACs, trial of labor, no trial of labor. We're going to talk briefly about that, but that's kind of a whole nother talk. Also on the website, this is your information. About 36% of your patients have an induction of labor for a variety of reasons. And we're going to talk about protocols later. However, you probably have, but I don't want to preach to the choir, but there should be protocols for labor inductions and so forth. And here's talking about maternal morbidity. You have the red triangles, which means it's higher than the state average. The yellow one means it's kind of okay, and the green one means it's lower. So for example, if you look towards the bottom, talking about hemorrhage, all hospitalization, you have a yellow circle, which is good. Quite frankly, when the state compares hospitals, it's not like they compare all the RPCs with the lower level hospitals. They put it, my understanding, they put everyone together. And I know the morbidity in your hospital for transfusions, this could also be University Hospital. I think it is in a way because we have the same issue. A lot of our patients come in, they're very anemic, require a section, or maybe they have an abruption, need a transfusion. It doesn't matter. It's a transfusion. They don't actually look at the reason for the transfusion because I guess it's getting a little bit too difficult and granular for the state to do that. But this is not a bad thing, by the way. It's just that you can find this information on the website. So going back about 5 or 6 years ago, maybe 7 years ago, but the target was 23.9, and as I said, now it's 23.6. The state actually published this, and I got this from the state website as well. And you can look at the green, the hospitals listed in green were at or below that 23.9. And at that time, RWJ was a little bit above that, okay? I guess the state got so much static about comparing the various hospitals that they no longer produce it this way. They just put it in the report card, and that's okay, as long as the information is there. So the question is why, why do you want to decrease surgical births? Well, obviously, we all want to do that. And then you can look at some of the reasons listed here. I mean, it's certainly shorter hospital stay, lower risk of DVT, less blood loss usually, reduced infection rates, less pain, and so forth and so on. So there's obviously a lot of good information. This actually is from the state website as well, Department of Health and Human Services. So yes, I think we all would buy into that we want to have our section rates as low as appropriate for a given population. And also we know about the complications. I show you here as a complication. Here's you see that little white thing on the bottom is actually the umbilical cord, as you probably recognize. This was a patient that had a accreta. She had several sections, and obviously, at the time of this section, she needed to have a hysterectomy. And obviously, there's a lot of blood loss, a lot of potential other issues that could occur at this time. And this is probably one that needed a transfusion that would go on that report card list and so forth. So this is obviously one of the main reasons, but there's others as well. This case, this is a patient who had a hysterectomy about 7 or 8 days after having a cesarean section. This is from an infection. At the time, she came in with premature rupture of membranes, was a breech presentation, so you have no choice. You have to do a cesarean delivery. Excuse me. And also, she was infected, and this particular picture is a whole nother lecture of the management of postpartum infections that I think we need to discuss at another time. But this is obviously very serious morbidity. And these cases, if aren't managed appropriately and effectively, can wind up in mortality. So how do you decrease the section rates? Well, it's a culture change by everyone. And a goal. Well, we know the goal for NTSVs is trying to get to 23.6% or less. So that's going to be the goal. But the culture change has to be with everybody. Everybody and anybody who comes in contact with the patient. So not just us as providers, not just the residents and the nurses and so forth, but even the office staff. And includes all office staff. I'll give you an example that happened to me a number of years ago. We had a patient who had a previous section, and I'm going to talk about previous sections for a second. And, we talked to her, and she wanted to have a trial of labor. So when she comes back for a subsequent visit, the clerk at the desk said, "Oh, hi, how are you?" And, after a while, you get to know patients and so forth. So she said, "Oh, you're going to have a trial of labor?" And the patient said, "Yes." So she said, "Why do you want to do that?" She said, "What do you mean?" So she said, "Well, I tried that and it didn't work. I was in labor for 8 or 10 hours. I had a lot of discomfort. They had to wind up doing a section anyway." Oops, there goes that one, because now the patient has a doubt in her mind. Does she want to go through 8 or 10 hours of labor or maybe more and still have a section anyway? Why not just do it from the get-go? So that's part of the issue. And then also when the patient finally gets over to labor and delivery, at the time she's in labor, hopefully, everyone in the hospital has to have the same mindset. And we also need to educate the consumer, because we still have some patients, thank goodness not a lot, that say, "Oh, I want a cesarean delivery." And I said, "Well, but there's no indication." No, but I want a cesarean delivery. My girlfriend, she delivered and she had to wind up having a section. I don't want to go through all of that. So the patient education obviously is extremely important on all things that we do, but also about this issue. Okay, let's see if I can get to the next slide. I'm having a little difficulty getting to my next slide here.
Is it not clicking over? You might want to press the escape button at the top left corner of your keyboard, because I see that you have annotation on.
Okay.
You need to turn annotation off, and then you can click forward.
See if I can click it off. Oh.
I would go to the lower left-hand side of the slide you're sharing, and a little icons should pop up, and one of them looks like a pencil, and you want to click on that to turn annotation off. Do you have one screen or two?
Let me try something else. All right, you know what? Maybe I'll just sign out and come back in.
You don't have to sign out, just stop sharing and then share again, and it will reset.
Okay. Okay. All right, I think we're good, Gary. So do you see review of stages of labor?
Yes, we do.
Yes,
Okay.
everything is fine.
All right, thank you. So whenever there's an issue that needs to be dealt with, I always like to go back to basics first, because sometimes it's just some of the little things that maybe we forgot or need to review. So I'm not going to go through this, but this is review the stages of labor. And, this is good for medical students and residents in the first month or two. By now, the residents, the first years are there for six months, so they pretty much know this. But I always like to go back and say, go back to basics. Let's see what we got. So, first stage of labor, prolonged latent phase. So I'm going to put this up here, but I'm not going to read it. You all can see it. But I will just tell you, I've been a consultant to several hospitals in the state over the past several years, particularly since this NTSV rate came out, whatever it was, 4 or 5 years ago. And one of the things we found in looking at patients who had cesarean deliveries at a particular hospital, I will not name the hospital, is that some patients were sectioned really in the looking back at latent phase for arrest of labor. Well, that's really not an arrest of labor if the patient isn't into active labor. So those are something that need to be brought to the surface and actually can be fixed. And the same thing, once you get into what is cervical dilatation that equals active labor or more, it's 6 centimeters or more. So when I was a resident, it was 4 centimeters. Times have changed. The data was reanalyzed. At that time, we used the so-called Friedman curve and so forth, but now it's 6 centimeters. So really, someone should not be sectioned for arrest of labor if she's 2 or 3, centimeters dilated, given all else is equal with that particular diagnosis. And then those who are at 6 or more, they need to have adequate oxytocin that causes effective uterine activity, and they should have at least 6 hours of that. And if they haven't had any change, they're still 6, and number of hours later, they're still 6, despite having, adequate contractions with oxytocin if needed. That could be an arrest of cervical dilatation. Now, as you get into the second stage of labor, these were a little bit of discussion. So this is what you'll see in the literature. I will say the longer a patient is in the second stage of labor, the higher risk there is of various obstetrical complications for the mother. However, before diagnosing arrest of the second stage, it should be at least 2 hours of pushing for a multiparous and 3 hours for a no-lip. Again, this is fetal heart rate is normal. There is no other issue and so forth and so on. So, however, if you find a patient at no-lip or, after 2 hours, it's still at 0 station, my suggestion is you get a more senior person to evaluate the patient, because if she's been in the second stage for 2 hours and the head is still at zero station, for example, maybe the baby's too big to come through the birth canal. Maybe there's some other issue. And sometimes what we'll find, and I don't know if I have it on my case list, but I'll show you that in a second. Sometimes these turn out to be rows that maybe are not compatible with a vaginal delivery and so forth. So reevaluate the patient, but these are the time limits that we use. So we shouldn't use just time alone. We should also use a clinical evaluation of the patient if she's not progressing the way we think she should. And I would say, at least to the resident staff, if you have someone on the RWJ staff that does forceps or vacuum, I guess vacuum is more common, try to learn that skill, because that's a great skill to have if it's done properly. And you can prevent a cesarean delivery by doing a vacuum delivery in the appropriate patient. So that's another way to decrease cesarean section rates. And traces, I'm going to show you something in a second, but go over tracing. So if we're doing a section because of, quote, say, abnormal fetal heart rate tracing and there's no other issue, you want to look at your traces, make sure we're making the correct interpretation. And also failed induction of labor. Some patients you have to induce for a variety of complications of pregnancy. And what's the definition of a failed induction in your institution? Do you have a definition? I know that's a tough one, but you should have a definition of a failed induction, because again, I've been giving some of these consults at the other hospitals. Some patients were called failed induction after 2 hours of oxytocin and no other issue, no other reason to section the patient. I'm not sure that's a failed induction of labor. So, review obstetrical cases, particularly patients who have cesarean deliveries, and I'll show you our case list in a second. We do it every Wednesday morning at 7 o'clock. We have the residents, the attendings, the medical students. We have our university hospital quality staff, because they're the ones that give our obstetrical information to the state of New Jersey. And we want to make sure it's as correct as possible. Certainly you all want to do that as well. Sometimes I was asked to go back and re-review a hospital after a year of going through their section rates and so forth. And sometimes you find there's a particular attending that maybe has a much higher section rate. And the hospital was saying, well, maybe there needs to be more education. And the answer is perhaps, but make sure if you're going to do something like that, that you compare apples to apples and oranges to oranges. And by that, I mean, I was asked to do that here about 12 years ago or so, although our section rate actually was pretty good, even at that time. And I looked at, by attending physician, the section rates. And lo and behold, the person who had the highest section rate happened to be a MFM. And, the hospital gets sometimes a little aggressive about this. And you say, well, wait a minute, this MFM happens to deliver only high-risk patients who have various problems, like that case of Accreta and so forth. So they don't go beneath the surface. They're kind of at, well, you got a high section rate, but you got to sometimes go beneath the surface. So compare apples to apples, so to speak, and oranges to oranges as far as physicians go, if you're going to do that one. So I want to go through this. This list is used for a variety. This was from last summer, or no, a couple of years ago, actually. We have our interesting cases. The senior resident on the obstetrical service presents these cases. And today we're only interested in the section part of it. So, for example, as we go through here, we also will have discussions about the medical complications, but obviously we're not going to do that today. I want you to go to case number 4. It said, here's a patient with a previous cesarean delivery, and she had a repeat low segment transverse cesarean. And the questions that would arise, why? Was she not a candidate for trial of labor? And here's where, this information gets out, why it was, why she wasn't. Maybe she declined it, was she offered it, and so forth. So this is talking about previous sections. And we're going to go to this list. Here's another patient, case 6. As you can see, she had a previous cesarean delivery and she had a repeat. However, she had a breech presentation. That's what the bean counters don't see. They see the section part of it, but they don't see it was indicated because she had a breech presentation. And then you look at the next patient, number 7. She had a transverse cesarean delivery. She had induction of labor. She had a medical indication for that. And the question is, this was a failed induction. And if you look over, I don't know, can you see my arrow? I don't know if you can or not, but if you look over where the baby's weight is, 3130, under it says 56 hours. This woman was induced for 56 hours before they called it a failed induction. Now, in my opinion, that's a little bit too long, but you got to have a protocol that kind of designate what's a failed induction of labor. Let's see what else we have. Number 9, patient with PROM. She had a section. She had induction of labor because of the PROM. She also was being treated for HIV, but again, we're not going to talk about that. Her induction of labor was 12 hours, which, okay, at least we tried for 12 hours and it was designated a failed induction. Case number 10, this patient would be an NTSV. She had a primary transverse. Question is why? She had a category 2 tracing. Okay, put the tracing up. We want to see the tracing. We want to see why this tracing was so bad that she needed to be sectioned. So this is an opportunity to review those cases. And we're just going to skip this last one. Last 2, I should say. I want to go to this one here. There was some, okay, case number 24. This is a patient that had a trial of labor after cesarean delivery. She had a vaginal birth after cesarean delivery. So this is the good feeling case on the list because it works on the appropriate patient to have a trial of labor. And we'd like people to see that in the audience. And this is reinforcement for what they did as well. And this was a whole team approach to this particular patient. So we were happy about that. So what you need to do is review the common indications for cesarean delivery. However, you need your own data. And the quality department probably does help you with that. And you just need to ask them to get the appropriate information by asking the indications and so forth. So if you look in the literature, and this was published, and I don't have the reference, unfortunately, but this particular study probably is applicable to a lot of hospitals, quite frankly. So this one is talking about NTSVs. So we're going back to the nulliparous term, singleton vertex, cesarean, and about 1/3 of those sections were done because of labor arrest. Now, hopefully that patient was 6 or more centimeters dilated. And about 1/4 of the sections were done because of non-reassuring fetal heart rate tracings, which again should be reviewed and studied to make sure that's the case. So you're talking about like 57%, if I add correctly, of the sections were done either because of labor arrest or non-reassuring tracing. So you probably want to do that if you haven't done that already and look at what is the indications for cesarean delivery in these NTSV cases. So can you reduce the section rate by review of fetal heart rate tracing? I mean, the obvious answer is going to be yes. You really can. Okay. How do you do that? Well, I just showed you by having, an NTSV case was done because of the fetal tracing, and we discussed it at the rounds, what was done, what was not done. So just in your own mind, particularly among your residents, here's a tracing of a patient in labor. And what category would you put that particular tracing? Here's a Another case in labor, she has variable decel. She's 6 centimeters dilated. So she's in active labor. But you see these, and these are repetitive. Now, the variability is still good here. Okay. So is there something that you can do, perhaps, to decrease these variable decels? Well, we know what causes, by and large, we know what causes variable decels is pressure on the cord. So if we can eliminate the pressure on the cord, or at least decrease it, you may find that these go away and you don't have to section the patient. So amnioeffusion. We can do an amnioeffusion. So that's a good tool to have. The issue of fetal scalp stimulation, that's the temporary thing to see if the kitty's okay. But this is not a, that one scalp stimulation we do at 8 o'clock in the morning, not applicable, probably at 8:30 or 9 if the decels are still going on. But amnioeffusion for repetitive decels is important. So you should have a protocol. And again, you may have this, and I apologize if you have this, but a lot of the things I'm saying today, there should be a written protocol, not just for the residents, but for all of us, the attendings, particularly in more private hospitals where they have a lot of private attendings doing the delivery. You got to have protocols that pretty much everyone understands why the protocol is what it is, and actually that they follow it. So this is our protocol. We have a very detailed protocol for amnioeffusion. Also, your oxytocin for induction of labor or stimulation of labor. Got a protocol for that? You probably do. I can tell you, going back 4, 5, 6 years ago, and visiting some of the hospitals where I was asked to take a look at some of the things that they were doing, there actually was either no protocol, very rudimentary protocol, that needed to be beefed up, and that's fine. That was able to be done, and it worked. And then failed induction. What we'll do with failed induction, as kind of indicated in that previous, but one of the patients, I said her induction lasted for 56 hours. You can stop the oxytocin after a period of time if it's applicable, rest the patient, give her some fluids and perhaps a very light meal, and then restart it the next day. Again, if it's appropriate, there's no other issue. Here's one that comes up on a kind of a frequent basis. You find someone in the clinic, 36 weeks, and hopefully we're still doing Leopold's maneuvers. I just remind you, there's 4 Leopold maneuvers. Most of us only do 3 because the 4th one, I don't think we can do anymore. But there should be a written protocol in the clinic. And again, you all may have that, and that's good. You have the patient who might be a candidate for aversion. That might be a way to decrease section rates for breech presentation. So the question, where should diversion take place? Got to be on labor and delivery. But your protocol would put that all in, and fetal monitoring before and after diversion and so forth. So these are things that could decrease the section rates. And you're going to see decreasing section rates by, we're not asking for 10 or 20 cases a month. I have some stats coming up where you'll see it makes a big difference. Also look for updates from ACOG. I can remember this, and this is Practice Bulletin 145. We had patients in these other institutions that I was consulting with. There were inductions of labor for no other reason than oligohydramnios based on an AFI of less than 5. Now, unfortunately, some of those patients wound up having cesarean deliveries because then everything else falls into place. Talked about some of the sections that were done in the latent phase and so forth that were not appropriate. So a 2x2 pocket is evidence of adequate amniotic fluid on the biophysical profile. But I think many of us use this even for when we're just looking at fluid. So that AFI of 5 or less, again, given all else is equal, fetal heart rate is fine. If you got a 2x2 pocket, that's probably adequate fluid. So this is the, I think it's an important slide because I know you do about 2,500 deliveries a year at RWJ. And if you perform one less nulliparous term singleton vertex, now we're just talking about NTSV. Now, I'm not talking about the VBACs now. That's a different time and place. So your NTSV rate, according to the information I got from the state recently, well, there was a few years behind in 2020, was 28.5. That means you did 712 sections that year that were nulliparous term singleton vertex. However, if you were able to decrease your NTSV rate by 1, you now have 721 cases minus 52, right? 1 week, there's 52 weeks in a year. You have 660 sections instead. Your section rate is now 26.4. That is fantastic progress. You don't have to go from 28.5 to 23.6, in a year or less, as long as you're making progress. And if you decreased it by 2, the NTSV is now 24.6. So a little tweaking here and there will actually significantly or potentially significantly decrease your cesarean delivery rate. So it's not, it shouldn't be that hard. If everyone is paying attention to all the details and reviewing cases and active labor is 6 centimeters or more and so forth. So, but go for the 1 section a week if you can do that. Also, we said look at non-reassuring fetal heart rate tracing. That may or may not be an issue in your institution. There's differences of opinion, and it is what it is. I mean, we have the same issue here. But review the tracings. That keeps everyone on their toes, including us, including me. And, we do that here. Also, our obstetrical staff, our nursing staff, they need to get recertified every year or every couple of years. What's a failed induction of labor? Was labor why was it induced? Was there a reason? Was there adequate time to ripen the cervix and so forth? And then we talk really briefly about elective repeats. So get your own rates. And again, you probably have that. You can have your quality department dig deeper. You may have questions. They can dig up the information for you from the stats. Look at all NTSVs, as we just said. You can do that. You don't have to do it every week. You can do it once a month, or you can have a subcommittee look at some of these cases and have written protocols pretty much for all of the things that you need: labor induction, amnio infusion protocol you probably have, what's the failed induction of labor, decrease the elective induction before 39 weeks. An elective induction means there's no medical indication. So if you have a patient that has preeclampsia with severe features and she shows up at 36 or 37 weeks and you need to deliver her, that's not elective. That's something else. This is a very hard concept for the non-medical people to get, the quality people. Part of the process, we have to they educate us on something, but we have to educate them. So, oh, this patient, she was only 36 weeks. Why'd you do the section? Well, Mary Jones, her blood pressure was 200 over 180 when, she had preeclampsia with severe features. Oh, okay. Excuse me. So it takes a while to get the quality people up to date as well. So you have a few tools. We're asking for 1 a week if you can, decrease your section rate. I think you can do it. You probably can. I think as these lectures come up, it just kind of puts us all back on our toes, including myself. I love to give this, this lecture for that reason, because I think it's, sometimes it's an old saying. It's what you learn after you know it all that counts. So, some of us get to a point where it's, we're pretty experienced, so that's okay, but let's keep going. Let's try to learn some more. And what I'd like to say, District 3 needs your feedback. This QR code, if you can scan it to give District 3, because we want to update the list of lectures. There may be other lectures that you would like, or maybe there's improvements in this lecture that you would like, and so forth. So District 3 is very happy to support these lectures, and we allow 2 per year for, our delivery hospitals here in New Jersey, Pennsylvania, and Delaware, and also for the Dominican Republic. We actually reach out to the Dominican Republic. So I want to thank you so much. And if you all have any questions, hopefully I don't have any auditory issues here, because I've been having a little problem with my computer. Thank you so much, and thank you, Gloria.
No, thank you, Dr. Apuzzio. Before we get to the questions, you brought up 1, 2, 3 for moms, and I just want to give everyone some background that Dr. Apuzzio was actually one of the team who went to Trenton to talk to Senator Vitale before Maternal Health Awareness Day became a reality, to really discuss how important it was. And there were 5 of us. I was one of them, with Dr. Apuzzio, Amy Pappy, Patty Hansen, and a Dr. Kiwi Liu. So we were there right from the start. And I would like to invite you, Dr. Apuzzio, to our Maternal Health Awareness Day, which will be taking place here at the New Brunswick campus. It'll be a hybrid, both in person and virtual, on January 26th, which is a Friday. So we would love for you to be part of it. And the last part is, we are asking for abstracts, for Maternal Health Awareness Day abstracts. So please spread that to your, resident students, staff, faculty, that we would really love to have abstracts from everyone. And there will be judging for the best abstract. So you really were very instrumental in moving that initiative along. That's so important, that now we have Maternal Health Awareness Day. And you actually brought it into the American College of OBGYN to make that part of ACOG's mission as well, or an initiative for ACOG. So for everyone on the call, please come to the 26th meeting for the Maternal Health Awareness Day and submit an abstract. With that, I'd like to start with the first question, which may be a little bit off base, but I think I'd like to bring it up. And that is, where do you see patient autonomy and a woman coming in and requesting a C-section and saying, I don't want to go through labor, I don't want to have all the issues that may occur afterwards with pelvic floor and so forth, even though she's NTSV? Is there any role for that? And the second part of that is, if she tells you that I really am not planning to have many pregnancies, so why can't I have a surgical delivery, cesarean delivery? What are your thoughts on that?
Well, Gloria, that's a great question. And I think patients pretty much, always have autonomy, unless there's some other perhaps psychological issue or disease, whatever. But I just answer that very briefly. This goes back when I was a young attending here at University Hospital, and we had one of the first reproductive endocrine clinics in the state of New Jersey, with a former chairman, Gerson was. And there was a patient that wanted to get pregnant who had previously been treated with for Hodgkin's disease. And at that particular time, part of the treatment, she actually got irradiated. So she had no ovarian function. She had no whatever. So she had in vitro fertilization and hormonal support, and she wanted to stay with us. So I inherited her for her obstetrical care. And she did very well, but we got to where it was in the last, I guess, maybe it was about 5 or 6 weeks before her EDD. And she said to me, and you get very close to these patients, by the way, because this was it for her. She hadn't had any children. You know, she was in her early 30s and so forth. She said, Dr. Apuzzio, I want to have a section. Now, at that particular time, you know, we hadn't, ACOG hadn't had much of a, I guess, a policy, so to speak, on section on maternal demand and so forth. After that, shortly after they did. So I said to her, I said, you know, but why do you want a section? She said, you know, just for the reason you said, this is my only baby and blah, blah, blah. And I don't want to jeopardize anything. So it took her like 2 or 3 subsequent appointments to convince me to do, this was an elective section, which I did. I got crucified by the department at that time because they said, why did you do that? And so forth and so on. But I think the bottom line is listen to the patient. Listen to the patient and make sure she knows the risk of a surgical delivery by, you know, by cesarean section and document. I was pretty doggone good in documenting that because quite frankly, I was afraid of medical legal implications. God forbid if she had a serious problem, you know, from the surgery or whatever. Thank goodness it went okay. And for the rest, up until now, this goes back a number of years ago, you know, we still communicate because, you know, you kind of become an extended family member with some of these patients, you know. So I think autonomy is good. Patients that want a section, I think it's up to us to explain to them the potential issues and risk and problems and so forth. And after that, if you feel, as I did, I felt that she understood, okay, I'll do it. So that's the short answer or long answer to your short question.
Now, because there is that issue of patient autonomy, and I think that I would like to, you know, include that in, you know, a lecture that what does the individual who is delivering the baby have to say about it? And you answered it very completely that, you know, you have to listen to the individual. You have to listen to the patient. Absolutely. And what her needs are. I have a few more questions, but does anyone else have a question? I don't want to take all the questions. Anyone have a question?
I see Dr. Dalal has her hand up.
Thank you, Dr. Apuzzio, for your lecture. I am actually trembling bringing up this comment in front of you. I think you partly alluded to this in your lecture, but do you really think that the NTSV rate is way too basic arithmetic equation because it's not representing the probability of a C-section in a patient who may be high risk? For example, you mentioned the fact that she had some patients have severe preeclampsia, some are done due to maternal deterioration. So perhaps even collaborate with a quantitative analyst to make the equation a little bit more complex, evaluating those probabilities of what the patient comes into and what are we trying to save her against. For example, a NICU morbidity or a maternal morbidity.
So you ask a really good question. So you're talking about the NTSV rate, and I kind of alluded a little bit. It's all comers. It doesn't matter if the patient had preeclampsia with severe features and she's 37 weeks and 1 day and so forth. And, you know, in trying to improve some of this, I think the state with their statistics, because that's where the data comes from, is based on what the hospitals give them. And I alluded to also those individuals in the quality department are going to, you know, the patient was 37 weeks and 1 day and she had preeclampsia with severe features and she needed to be sectioned. She goes with the NTSV rate. That's what they're going to give the state. So I think it's what it would be nice if we can get and find out really what the indications were for the NTSV rate. But I think that's a little bit too complicated, unfortunately, for the state to figure out, you know. So, because I'm sure your NTSV rate, well, ours is actually pretty good here, but, you know, a lot of it is going to be indicated medical decisions of that particular patient and so forth, but it's still going to go down as an NTSV as far as the rate goes. So that was a good question, but I think the state does the best that they can, given the resources in their department that they have. Would it be better? Well, I guess if they had more funding to do some of these things and hire more people to actually take a deeper dive into NTSV rates as far as the indication. But I think they have a challenge with that.
And then because in the economic land, we have quantitative analysts and they make more complex and statistical probabilities, perhaps even collaborate with them to see if we could come up with a number that's more representative of the population that a hospital is treating.
So I don't want to give him extra work, but you have an excellent person, Dr. Ananth, who, if he could engage the state on some of it, but again, I think it's a challenge with personnel issues that they just don't have at the state to take a deeper dive in that. However, that might be a question for you to ask of your own quality department at RWJ. Oh, okay, we did, what did I say, whatever it was, 600 or so, or 700 NTSV. Can you tell us how many of those patients had medical complications of pregnancy? So you might be able to get your quality department to help you, at least with your own data. And then if you get that, you might share that with the Department of Health. I think that would be a good educational process for the DOH as well.
Thank you.
See, Dr. Silverberg's hand is up.
Hi, thank you so much. That was excellent. Dr. Apuzzio, I've been following your long and distinguished career for many years, first at Morristown and now here at RWJ Medical School. I am chairing the NTSB committee along with one of the residents, Dr. Gabriella Lobitz, and we look at every NTSB candidate that has failed. And so every month we look at between 10 and 15 failures, and generally we'll find several people who have had elective procedures that could possibly have been avoided. And also we have people who have failed the certain criteria that we've outlined. But my question is, how could we somehow impact effectively using these statistics? What I generally do now is I alert the individual physicians who have failed those criteria, but I believe we could really impact much more, let's say by teaching skilled use of forceps, by waiting even longer than the minimum amount that are the requirements for, let's say, failed induction or prolonged first or second stage. So I just wanted to know your comments on those.
Well, first of all, Dr. Silver, I got to congratulate you, because it looks like you're actually getting the data, or at least some of the appropriate data, and you're trying to deal with it. And I think you're right. I just gave some of the, I think I want to say easier tools to employ that to decrease the section rates. Your own stats are really the best stats to have. Okay, what happens at other hospitals or RWJ, Somerset, and so forth may or may not be totally applicable to you all at RWJ. And I think going over, or you probably have this, but if you have a meeting with the residents and attending staff periodically, it doesn't have to be every week and doesn't even have to be every month, to just keep going over some of the basic things, some of which you just described. So these are minimum. Some of those things about, 6 centimeters or more, giving oxytocin, as I employed in some of our cases, we induce labor 56 hours. That might be a little bit too long, and she had to wind up getting a section. But I also have a lot of information that I didn't share with you, because a lot of those patients, similar patients, will get labor induced, and after a period of time, they'll actually deliver vaginally. So I didn't give you that information because I didn't have it as part of this lecture. So I think sounds like what you're doing is good, but you got to get the attending. And then the other issue is if you have an outlier, okay? So and let's say we're going to compare apples to apples. So all the generalists, for example, who do cover labor delivery and have cesarean section, over a period of a year or 2 years, you should have some data. And if, I don't know, Dr. Apuzzio is a generalist on your staff, I know I'm not, but if I was, my section rate was appreciably higher than, you know, the rest of the generals got to say, hey, wait a minute, maybe we got to go look at Dr. Apuzzio, see why, you know, look at some of those cases. So sometimes you have to get granular with some of the issues. That's not the most pleasant thing, but that's a way to help as well. And also, if people know you're watching the store, which you are, you're watching the store, you're watching the section rates, not just overall, not just the NTSV, but you're also watching individual providers. That may help a little bit. We're looking for one less section a week, so I think that might be doable.
And the other thing is, in answer to Dr. Dalal's question, the NTSV rate is actually very liberal. If you are skilled and if you have patience, you can probably get to about half of what the rate is now. If you're doing all those things. So it's a 23.6% is a very, very liberal number. But still a lot of people struggle to get to that number.
No, you're absolutely correct. If you look at the World Health Organization, their primary section, and we'll kind of put it equivalent, is like, I think 15%, their recommendation, or it's like 15% or something around that number. So you're absolutely correct. 23.6 is kind of a liberal number. Yeah.
Thank you.
I see Dr. Goldberg's hand is up.
Hi, thank you very much for this talk. You know, this is a topic that's near and dear to my heart. I'm the chair over at Raritan Bay, where the residents rotate and we have students that come. And we had a terrific NTSV rate last year that started inching up this year for no obvious reason. And it's become a real thorn in our spine to try to get the rate back to where it had been. So, you know, these things, and there's so many different reasons. And I, as you say, the most two common reasons are, you know, for what we used to call failure to progress. And the other is the non-reassuring fetal heart rate, you know, and I think that everyone has a different level of non-reassuring. You know, unfortunately, it should be uniform, and you know, what's non-reassuring to me should be non-reassuring to you. But I think that what happens is the less experienced people are concerned about certain patterns, and then they rush into the room, and it gets the patient worried, and now the patient worried, and the nurse is worried, and then the attending gets worried, and so it's a circle that just keeps feeding on each other. And really, what it needs is learn to read strips correctly, and not call variables lates, and recognize beat to beat variability. And I think one day, and I'm hoping sooner rather than later, we will have the ability, you know, with AI, and that those strips will be read, and recommendations will be made based on, you know, statistics and data, where, you know, you could plot everything into the system, and it comes back and says, you know, some type of prediction that there's no acidosis here, there's no pre-acidosis here, and labor could progress. I'm hoping that'll happen one day, but and maybe if not in my lifetime, in our residents' lifetime. But I appreciate the talk. The other question I had is, how did we get to, like, I know who decided 23%, but is there data behind that? And we don't know the answer to this, I know that. What's the right number?
You know what, you in fact, just keep doing what you're doing, paying attention to the traces. I think that some of that is enough to, you know, keep it on the front burner so people consider things rather than say, oh, the trace doesn't look good, we're going to section the patient. The other thing is, who sets these numbers? So some of it, as I said, the World Health Organization actually has much lower numbers. The NIH was involved a number of years ago. So they come up with these numbers. You know, how much is too much? How low is too low? And you know, the answer is, I'm not sure anybody really knows, but I think most people agree that the section rate was too high, and they put some bar that we have to meet or try to meet. And I think the important thing here, are you going to get to 23.6? I alluded to that before in the next year or two. Maybe not, but you're trying. And your section rate probably going to come down if people pay attention to some of the things you said, and also Dr. Silverberg, as well as what I said. But I think that's why it's good to have these lectures every so often. You know, do you need it every month or every year? Maybe not, but maybe every couple of years, just go back and revisit, go back to basics. So, Dr. Goldberg, I congratulate you on what you all trying to do.
Thank you,
Hard
Doctor.
work. It's hard work.
It
Thank
is.
Thank you, everyone. Thank you so much, Dr. Apuzzio, for an excellent presentation, but we are just about out of time. So I just wanted to wish everyone a great day.
Yes, thank you so much, Dr. Apuzzio. This was amazing, and we could have continued with Q&A for the next hour, I'm sure. I see other hands up, and I had many other questions too. Thank you.
My pleasure. Thank you so much. Have a good holiday.
Thank you.
You too now. Bye-bye.